Welcome everyone to the kickoff presentation for PatientValue Insights. I'm so delighted by the overwhelming response, and it's not every day we get to discuss how to keep your CFO from becoming the star of a courtroom drama. So we're here to talk about why employees are suing their employers over health benefits, and most importantly, what you can do about it. One disclosure I need to make is that as the plaintiff in the J&J lawsuit, I will not be taking questions on ongoing litigation. So, welcome to the team. I am so excited to have you all joining us. I'll introduce myself, and then Jennifer Stanley and Steve Ditto will each introduce themselves in turn. I've worked in healthcare since I was knee-high to a grasshopper, or over 30 years at this point. I became a patient in 2008, and I saw the perverse incentives from both sides as I worked through the industry, and often how these incentives hurt patients. In 2021, I began learning about the Consolidated Appropriations Act and fiduciary duties under ERISA. Now I'm the plaintiff in the J&J case, and I decided that health plans, and particularly plan sponsors, needed help aligning their plan interest with the beneficiary interest. I'm completing a Master's of Legal Studies in Health Administration and Health Law and Compliance, and I founded PatientValue Insights to deliver the value of helping plan sponsors aligned with their beneficiaries' interest. So I've already introduced Steve and Jennifer. Jennifer, do you mind introducing yourself?
Thanks, Anne, and thank you for sponsoring this webinar. I'm so delighted to be part of the panel. Jennifer Stanley with Stanley Cup Legal and Compliance, and I had my first career in clinical trials and then went into law school when the market crashed. So this has been 10 years of doing employee benefits law, just on the health and welfare side. That's all I do. That's all I know. That's not all I know, but that's definitely my area of expertise. And with that, I started my own firm about a year and a half ago, where I help employers as plan sponsors or a plan administrator, TPAs, point solutions, employees, brokers. It really doesn't matter. I'm an equal opportunist to help those who need and want help, because everyone needs help, but those who want help get the information and get across the finish line. That's me in a little bit of a nutshell with a little bit of rambling. Now on to Steve Ditto. He has been in this space for 30 years in the health plan space, primarily doing governance. Steve with Steve Ditto and Associates, will you tell us a little bit about yourself?
Yeah, Jennifer, thank you. So as you said, been in healthcare forever. I've been a healthcare executive and a compliance advisor, and now turned into a bit of a patient advocate as well. And I've worked across the entire spectrum. I've worked with health plans, hospitals, digital health companies. And during that time with a few of those, I've sat on benefit committees, and I've experienced firsthand how they work and a lot of times how they don't work. And then a couple of years ago, I developed an autoimmune condition. And so really saw healthcare for the first time from the patient side. And I often think of it as the broken side, and hence the patient advocacy. And so now I'm using my professional expertise and my personal experience, and I'm trying to help companies improve their compliance and lower their costs and deliver better benefits to their plan participants, essentially employees and their families.
So Steve, why don't you give our audience a little bit of an overview of why we're here and a key learning objective?
Yeah, absolutely. So I think we have a little something for everybody here. And just looking at the poll, we've got a good cross-section of people. And so this is, I think, going to talk to everyone. First is everyone's going to understand the new bar, the new and higher bar for health plan fiduciaries. We'll talk a bit about that. Then we're going to hear some real examples of fiduciary failure, right? Where the company and the plan didn't follow those rules, and as a result, there was litigation, employees suing their employers. And in particular, we're going to dive into prescription drugs and a mental health. then, the really important part of the so what, the takeaway is what can you do about it? How can you safeguard your plan and your participants? And we'll talk about that. So I think the takeaway for everybody is really, we hope you're going to have our belief that compliance is not just about preventing lawsuits, that when it's well done, companies can achieve compliance and cost savings and better benefits and ultimately satisfied employees. So, Anne, I guess the question is, how do we take that first step?
I think that's such a good question. We were discussing that as we were getting prepared for this webinar. We have sort of outlined this process, right? Getting this roadmap. But Jennifer, one of the comments I really love from you was the fact that there's this big mud puddle before you even get on the road. So this has actually become one of our turns of phrase throughout the presentation. Why don't you share with our audience, what do you mean by this mud puddle?
Yeah, and we took a poll. I don't think we were quite live yet, new platform, but this is really for our plan sponsor, which is the employer in this case. And as in the private sector especially, employers are making widgets and running payroll and putting people to work. And then they have to offer this thing called benefits for recruitment and retention. Unfortunately, I don't think a lot of them understand what that means to be a plan sponsor. They don't understand that likely name, they are also probably named the plan administrator and the named fiduciary. So while we in our expertise and in our point solutions and in our services are all up here on control and cost containment and implementation and claims analytics and all these other things, our employers are in the muck and the mire of just trying to figure out what the heck we're talking about. And so, first off, we need to help our plan sponsors, employers pull up their bootstraps and step onto the pavement through education. Ironically, real quickly, the second step after education is the governance. And those two things are ongoing. All of this is ongoing. The governance that we actually do see a lot is in those spaces where there is in the public sector, right? They do governments because guess what? That's their job is to do governance, whether it's a school or municipality, county, and then we see it sometimes in the financial industry. And Steve can kind of touch on that and why they might have a leg up in a way, but also still be in the muck and the mire. So let's just kind of take stock of where we are, be honest of where we are, what we don't know, and we are here to help along the way.
Yeah, and I think that's such a good point, right, Jennifer? And I know a lot of people, even just starting around education, right? I've heard people say ERISA is the only law that applies to a self-funded plan. And I'm going to throw a whole bunch of other terms at you. If you don't know what they are, right, it starts to be a concerning problem because you may not be able to ask the questions that help you make informed decisions, and that prudent decision making is a core responsibility of a fiduciary. So the Health Insurance Portability and Accountability Act, do you know what a third-party administrator is? Do you know what a pharmacy benefit manager is? What's the Consolidated Appropriations Act of 2021? Of course, are you an ERISA plan? Are you covered under the Employee Income Retirement Security Act? If you're a government plan, you're not. But the Mental Health Parity and Addiction Equity Act does apply, as does the American with Disabilities Act. I really approach governance as a structured decision-making process, as well as the committees and structure that help protect you. And Steve's going to talk about that with some of the legal cases and how that impacts personal liability. And then you probably want to start assessing, how are these plans actually working for your participants? Are they working well? Are people coming to your HR and saying, I'm paying too much for this drug, help me? And if they are, do you have a process to assess and implement a different process and then control for that process and make sure it's really coming to fruition? So I think that's a lot.
Process, real quick, by process, do you mean just like a conversation, or do you mean like document, like a process? Like written.
I'm talking about a real process, right? I come from a quality improvement standpoint background. And so when I say process, it's an evaluation, it's documenting in your committee meeting minutes that we have discussed XYZ, that we have thought about, you know, we're not getting, for example, we're not getting data from a vendor. What are we going to do about that? We're not simply going to accept, no, we're not going to get our data, because that creates significant concerns with the data reporting elements that you have to provide. So I also want to say, you're not required to be perfect. You're required to be prudent. And so as you move through this path, you really just want to understand that you shouldn't have analysis paralysis. You can't not do anything. But as you're doing this, you really do need to exercise that prudence and diligence. So, Steve, I know that there were activity in the 401k space. Do you mind walking us through some of the differences that we might see in the 401k space as compared to the health plan space?
Yeah, and absolutely. And so you're exactly right. ERISA has been around. It's been around for decades. And there's a lot of relevant lessons of what companies, organizations went through with ERISA being focused on retirement plans, essentially pension and 401k plans. And there's a lot of lessons for health plans. So, with that original focus on 401ks, employee lawsuits under ERISA forced real changes. And they came in some pretty relevant places, relevant to health plans, unreasonable fees, poor disclosure, conflicts of interest. And even though it's been around for, years and decades, it's still ongoing, right? And, I think as you said earlier on the roadmap, I mean, it is a continual thing. And, just literally this week, I received a notice of a class action suit settlement against Vanguard, right? A really well-regarded, generally well-managed investment firm. And I'm going to receive several $1,000s based on poor decisions that Vanguard made around taxes that cost me more money, right? Took money out of my 401k than they should have. And so now with the passage of CAA, which you had mentioned earlier, the Consolidated Appropriations Act, that's really focused more of ERISA's attention on health plans. And so just like the Vanguard example for just a second, let's imagine, can you imagine health plans having to reimburse participants because they overpaid for medical and pharmacy services? Well, you don't have to imagine it. It's going to happen. And it is happening. We're going to talk about some of the lawsuits where that's ongoing. And so the bar's been raised, right? The level of responsibility is higher, and employee-sponsored health plan fiduciaries need to step up to it. So let's take a look at those duties, right? And the first one, first and foremost, that I want to call your attention to is ERISA requires health plan fiduciaries to act solely in the interest of participants and beneficiaries.
I'm sorry, did you say solely or only or kinda?
Kinda. So
Kinda.
solely, right? So the key, I think maybe misunderstanding or lack of understanding on the part of, certain companies and fiduciaries is they think it requires them to operate in the interest of the plan or the interest of the company, or in the worst case, in the interest of company executives and their golfing buddies, right? But that's not the case, Jennifer. It is in the sole interest of participants and beneficiaries, and that's a difficult thing. It's it's something that's legally important. It's ethically important to understand that difference. So the couple of key takeaways here is that there's actually some duties, some responsibilities that are called out. And it's around care and loyalty and good faith and prudence and disclosure and diligence. And those aren't just words, they aren't adjectives. Those are, all of those words have legal meanings that fiduciaries, need to follow. And, when the plaintiff attorneys show up, they are going down that checklist to show, as you said earlier, did you do these things? And, oh, by the way, was it documented, in a way that you can prove it? And so bottom line is that, compliance is no longer a check the box exercise, right? And you have to make thoughtful and informed decisions. And so the last bit of a big takeaway here is, as you're probably all aware, insurance companies and the pharmacy benefit managers have all been hauled up in front of Congress. Over the past few months, they've all been making public statements and disclosures. Almost 2-1, they've said, we're not fiduciaries. We don't want to be fiduciaries. We have no intention to be a fiduciary. You can't hold us to a fiduciary responsibility. And so what that really means is that you as a plan sponsor and the fiduciaries that are helping manage that, your job is to protect your participants from those service providers who are not fiduciaries and are just acting in their own best interest. So, I guess what I would say is, Jennifer, having been out there right in the market, what have you seen?
Yeah, so it is interesting. We say if it walks like a duck, talks like a duck, it might be a duck. With a fiduciary, and guys, if y'all put questions in, we'll get to those at the end. So just keep them coming as they pop up. All right. And if we don't get to them at the end, we'll email following the presentation. So we're seeing those come in. The thing with the named fiduciary, employer, plan sponsor, that is likely you. And whether it's you as the company name, or maybe you have a benefits committee that is named, but more than likely, unless you had an attorney draft your documents, personally draft your documents, and then you reviewed them and made them tailored, it's likely that the employer is named as the plan sponsor. Y'all funded the plan, you started the plan, you amend, you terminate. The plan administrator, you provide oversight of all the service providers and the named fiduciary. And the thing is those things have personal liability attached to them. And so that's big. I know he jumped, but I'm still in my own thought process here. So it's the what hat is the employer wearing, right? And the only way to do that is to have good documentation. And when we say documentation, we also mean governance. We need good documentation, good governance that is on that roadmap, and it is ongoing, and it is naming not by Jennifer Stanley on the benefits committee, but our benefits committee, and it is comprised of so many stakeholders who might have a specialty in this area, a couple of employees, right? I mean, you have the responsibility to put that together, and don't outsource this to HR. Don't outsource it to HR. Bless their hearts, right? They're human resources. They're not, and so there's a lot of responsibility that goes into this, and we are seeing what is at stake for those fiduciaries. And one more thing, they might not say they are a fiduciary, but if they're using discretionary authority, they are, and function. But you only prove that through litigation, right? That's why we're here. Steve?
Yeah. So that's super, super helpful. And so, I think you touched on, one of the other key takeaways here is that fiduciaries are personally liable for not fulfilling their duties. And that means perhaps even especially if they didn't realize they were a fiduciary, right? And as they say, ignorance is no excuse for the law. And just as, one example in the Wells Fargo case, which everyone here has probably heard about, we're going to talk a little more about it later. There's a class action suit, and it's named over 20 plaintiffs for breach of fiduciary duties. And the lawsuit named nearly everyone that was a part of their benefits committee. And when you think of it, 20 fiduciaries just around managing their prescription drug benefits. I mean, could be so many more in there that are, focused on medical and other areas. And so that should be a real wake-up call and it is a real compliance failure on the part of the company to not set up all the structures that Jennifer was talking about. And, they're relatively easy, and they may even have already taken those steps for their 401k or their pension plan, right? And it's, let's have a committee. Let's have the right people on the committee. Let's authorize the committee with a board resolution. Let's give them a charter so they know what they're supposed to do. Let's delegate authority appropriately. And let's let all these people that we identify as fiduciaries know they're a fiduciary and acknowledge a fiduciary. And so I guess, Jennifer, back to you, and I know this is an area of passion for you. I'm just really curious. Do you see a lot of employers doing this today?
And Steve, I'm just going to jump in here for a minute. One of the other pieces is once you know you're a fiduciary, right? Like you can take steps to protect yourself. You can take out liability insurance or, other, and then as a committee, maybe you require that liability insurance for your committee members to know that they're protected.
Yep.
And so, Jennifer, like, again, I think it's a really great question that Steve asked. What are you seeing when you're talking with these employers and, others who might be influencing their decision making?
Well, I see a lot of governance and committee work and resolutions, again, in that public sector space, right? I mean, it's their job. But for the private sector, their job is making widgets and running payroll. And they know, again, they know they think they have to offer this thing, right? This thing, and they're just trying to get by. It's expensive. It's a growing cost. People are griping and complaining, and it's never good enough, right? And so the entitlement that they're probably experiencing, and the frustrations, and but if it were, we all know that if you take certain steps to create guardrails and create efficiencies, that those things are handled without emotion. They're handled routinely, systematically, and it's not about the outcome. It's not about the outcome for the fiduciary component of it. It's about what steps did you take? Can you demonstrate that you took steps? You cannot outsource all of your fiduciary responsibilities. And if you are outsourcing it, the other party has to agree to accept it, right? So there's those contracts that you might want to read, and you probably attested that they're all fine and good, but maybe you didn't read them all. Period, space, find your contracts, see what your responsibilities are, see what their responsibilities are. And then start small, form that committee, document it, and get out of the mud, right? Get out of the mud.
Get out of that mud puddle, Jennifer. Yeah, absolutely. And what I hear you keep touching on is diligence, right? And just because someone tells you they did something, right, doesn't mean that you should accept it, right? You need to drill in for full disclosure to understand that it's been done, and it's been done to your satisfaction and to the letter of the law. Yep.
And I think one other thing that I'll note, to Jennifer's point about how you make these decisions, right? Consistency is really important. And we don't have a ton of class action cases in the health plan side, but we do have cases around denied benefits where a third-party administrator acting as a fiduciary is held liable. And often it's because of failure to have independent outside providers looking at things, or an arbitrary and capricious decision-making process. And so I think that those are pieces that fiduciaries really should be watching for as they start to come up and emerge from the mud puddle. Steve, why don't you talk about some of the cases from 2024?
Yeah. So, I love this, right? It's, there've been, legal cases that have been percolating, for quite some time in this space, but last year was a big one. Right. And two of the big ones came out in two ERISA cases around pharmacy benefit managers and mismanagement of the pharmacy benefit. And one, that we're all familiar with, I think, is Lewandowski versus J&J, and everyone's watching that one. And the other we mentioned previously is Navarro versus Wells Fargo. And we're going to talk about that one in a little more detail. But both of these cases, just for background, were brought by the same deep pocket law firm that's, and bringing class action suits is expensive, takes a lot of resource and expertise, and these firms have it, right? And they are focused on prescription drug pricing, and they're alleging a failure of fiduciary responsibility around vendor selection, contracting, pricing, right? And there's all the governance and all the discipline and diligence issues we've been talking about. So that's a big one. The other big one to watch is around mental health, and we're going to talk significantly around that one because we believe that it's a really big already and maybe somewhat silent but emerging area of action. And in this case, SMO versus Mayo Clinic, you may see it referred to as, and I've been asked, SMO is the initials of the unidentified plaintiff in the case, that they focused on high plan cost, lack of timely decision making, and interestingly, a ghost network. And a ghost network is when there are providers in the network directory who don't see patients, and either because they aren't actually in the network, or they don't take insurance, or they moved, or they died, right? Hence ghost network. And so interestingly, in this case, the lawyers in the group have focused on ERISA, mental health parity, and they believe there's some benefit, right, to taking that course of action. And this is a real hot topic, and we're going to talk about it some more. The last but not least, in a really interesting twist and big name, is Owens and Minor, right? And in this case, they're suing their TPA, Anthem, and they're alleging mismanagement. And they really got to jump on things and felt that they were at risk, and decided that their best course of action was to sue first. And so, we think we'll see some more of that. So just, I'd say some takeaways from this slide is, and maybe some predictions. We'll go on a limb and predict here. You heard it here first. On the PBM side, we think it's going to continue. As I mentioned, these big law firms are in it to win it, but it's going to take a while, right? Class action sometimes takes years to percolate, and other law firms are sitting on the sidelines. They're not going to jump in until they see some results and they see some case law established. And so when people say to you, perhaps, oh, it's just two, well, there are big two, and there's a lot more, in that iceberg, as they say, under the water level. But the key, I think, takeaway is that smart employers will and are taking risk off the table, right? So they're doing the discipline diligence, right? They're issuing RFPs, they're forcing disclosure, they're looking at formularies, they're reviewing plan design. Second piece is back to the Mayo Clinic and more broadly, I guess I'd say mental health, right? We're going to see not just ERISA action, but we're going to see a lot of individual action. We'll talk more about this, but employees are going to be able to and are contacting Department of Labor, their state attorney general, and rather than a lawsuit, it's resulting in an audit, which is no fun. It's a real burden. It's costly. And no one wants to go through it. May not make it on the front pages, but it's happening significantly. We'll talk about that. And then the last one is back to Owens and Minor, the sue or be sued mentality. This is really interesting because, pulling together a class action suit is hard, and you have to find, develop a class. But in this case, a company with, pretty deep pockets and their own general counsel and some outside counsel can just say, hey, we're going to sue, and we're going to get this money back, and we're going to do the right thing. So, we think we'll see some more, on that. Jennifer, I know you're seeing stuff on a daily basis. So what else can you add?
Yeah, I wanted a couple of things. One, you talked about ghost networks, and that just fascinates me, right? Because we're sitting here talking about the CAA, comp disclosures, gag clause, transparency. You know what one of the provisions is in the CAA is that cost share tool, section 114, personal price tool, January 1, 2023, 500 Googleable things are supposed to be available on site. I don't need the CPT code. I just need to know sleep study. January 1, 2024, all items outlined in the transparency and coverage rules are supposed to be available for me, consumer, to shop online or call for a real-time estimate based on my spend, and my provider, right? So my provider. So employer, I bet you're paying for that tool. Have you used it? Do you know if it's available? Are you encouraging and teaching your employees and participants to use it? Is that something that your consultant is also helping facilitate through whatever, right? And I'm not driving a bus. I'm just bringing to light, as Steve, this is impromptu improv here, commentary on my part. So, Anne, if we go over, I'm sorry. But that occurred to me. This cross tool is supposed to be out there for that ghost network combat, right? Combat type of situation. Fascinating. The other thing is the regulatory action. And it's not new. In 2021, the Department of Labor, and I believe it was New York Attorney General's, don't quote me, but they sued United Healthcare, and they settled for $15.6 million, drop in the bucket, for mental health violations. And then in 2023, the DOL sued UMR, which is the biggest TPA in the country. And this one's fascinating to me. They denied allegedly denied all urinary drug screening from August 2015 through August 2018 as not medically necessary across the country. Through 2023, it was still going on. They did not provide appeal rights. They did not follow the plan documents, and they just demonstrated a systematic failure to address claims properly. That right there is what we would call a fiduciary in function, using their own discretion to deny or approve claims not in line with the plan document. God, I'm an equal opportunity offender. I apologize. So that's what we're seeing in the regulatory space. One more thing is mental health parity. These are humans that come in, a mom complains, DOL, Department of Labor will come in locally. So these are people in their own community, in their own backyard that can't get the benefits they thought they could. And I'll push pause on that, but just please understand that that is a big one. And it's not going away.
And we do have a comment that our faces, beautiful faces, are obscuring some of the slides. We will be happy to share the slides after the presentation. We do apologize. This is a new platform to us, and we have had a few speed bumps. So thank you for that. So generic medications. When I go to plan sponsor meetings or listen to discussions, I rarely hear a focus on generic medications, but I really want to emphasize what the risk is for people not paying attention to the cost here. So depending on the statistics, between 80 and 90% of the medications dispensed in the US are generics. That actually means that up to 75% of your employees in the age group between 50 and 64 are on at least one. Some are on 5 or more. So that becomes a huge risk. And then yesterday we had the FTC, and this is of course controversial, release their second report on the generic specialty market. And they highlight that PBMs made more than $4.8 billion on specialty generic drugs, driving $297 million in patient cost. And between 2017 and 2021, plan sponsors and patient payments increased at a compound annual growth rate of 21% for commercial claims. Those are claims that are not Medicare or Medicaid for that. So those are huge numbers, 21%. And so, Steve, I know that you are one of these patients on multiple generic medications. Do you want to talk about your personal experience with the cost?
Yeah, and so started this by saying that I'm a patient advocate. I think it's this issue that got me there personally, right? So after having never been sick, never been in the hospital, got this autoimmune condition, and I'm now on 7 generic drugs, and they're supposed to be the cheap drugs, so you think, but with my supposed good insurance, was paying about $1,000 a year for these 7 generics. And I wasn't real happy with that. But when you started seeing, the congressional movement, hear Mark Cuban talk, I went and looked around, and I looked at GoodRx, and then I looked at Mark Cuban, and then I found a transparent pharmacy locally, and I'm paying about $100 a year instead of about $1,000 a year. And so, that's a gross overpayment, and certainly, didn't make me happy. And beyond that, if you think back to my Vanguard example earlier around, lawsuits, whether it's in the 401k space or the health plan space, being launched and won around overpayment, whether it's, fees or taxes, or in this case, generic drugs, this is just a massive lawsuit ready to happen. And, if I can, with a quick Google search and go to, 2 or 3 websites, find that my PBM was overcharging me by 10x, something big is going to happen, right? And the last thing I'll say is, I thought, oh, I must be an outlier. These, 7 drugs that I'm on must be, way, more expensive for some reason than others. Well, I went and looked at the top 50 drugs, and in fact, for the top 50, it was more than a 10x markup. So I was getting off easy, I guess.
Yeah, and I really think, especially this area of generic specialty, right? Specialty was originally designed to be complex handling, really thoughtful, and now the category has really exploded and includes these medications that are really expensive. And so the case study that of somebody who approached me, and I really want to emphasize this part of it, that she had approached me to introduce her to lawyers after she had gone multiple times to her plan sponsor saying, I can find this drug for $9 at a cost plus pharmacy, right? This is not the cheapest. This is not some crazy, we're going to do an ingredient based cost measure. This is simply a cost plus market that's cash pay and available to patients. She was paying $20 every month. Okay, that doesn't feel like a ton, but it's still more than twice the cost plus cost. Her plan was paying $1,100 every month for this specialty generic. And so that's where it really starts to compound for plan sponsors, this cost, because after all, today's expenses that come through the plan are tomorrow's premium, and they drive cost for every single patient on the plan. And so that's another way of harm that could translate into a class action. And so in this case, a patient is overpaying by $100 or more than $100 for a single medication. The plan is, overpaying potentially by $13,000, right? That's what $1,100 times 12 looks like. And so what you really want to structure is, do you have a prudent and process for this purchase that is the massive part of your drug spend? How are you structuring this? Are you allowing your PBM to say, these are specialty meds and we're going to charge you 500 times what we're acquiring them for? I think those are the types of things that plan sponsors are really going to wrestle with in this space. But as Steve and I have done some numbers, we're looking at, as he said, putting $800 back in your employees' pockets. That's huge. And then you start to look at, wow, what are the savings across a basket of medications? Potentially $114,000 per 1,000 employees. That really starts to add up significantly. So this is an area where we are very passionate, because it is such a risk for you to not have a process and not define how you want to purchase these medications. Number 2, mental health access. Steve and Jennifer queued this up really, really well. And so we have 2 cases. Steve talked through the SMO, that's a class action on the ERISA side, the Blue Cross Blue Shield of New York, and there's also a federal employee mental health parity lawsuit. And so there is a class action firm specializing in non-ERISA cases, really focusing on those government health plans. And what they're looking at is this issue of ghost networks. What's a ghost network? Well, we probably all had the experience where we look at the provider directory, which is the TPA or insurance networks, saying these are the people in network, and you expect to be able to call, and they're either taking new patients, often it says that they are, and if they are, be able to make an appointment. What happens with the ghost network is that they are not in network and they're not accepted. And so you have this challenge of your network actually being much, much smaller and potentially not supporting the mental health needs of your employees and beneficiaries. Now, we have a mental health crisis in this country. I'm going to talk a little bit about a plan that I looked at just last week. They had 8,000 members. The top 5 diagnoses that we identified on their claims data were all mental health related. That's huge. The top two of three reasons for being inpatient were also related to mental health. So what we're seeing is a drive to seek these services at an unprecedented rate. And let me tell you, moms whose kids are being denied or dads whose kids are being denied, these are not people that I want to mess with. They are passionate people who are going to go to the mat for their child so that they get the services that they deserve.
Yeah. And hey, and just to pile on for a second, but we're also seeing not only unprecedented levels, but I think unprecedented areas that maybe not everyone thinks of as mental health. Boys, as an example, that are having eating disorders and dysmorphia and other kinds of things that maybe weren't seen or maybe weren't talked about previously, and certainly suicidality and at least thoughts of suicide at unprecedented rates as an example. So it's just such a big issue to get in front of, because litigation is too late, right, to head those kind of things off.
A couple of things jumped out at me on this. One, we're talking about the ghost networks, and there's another thing that can happen is we would get these fees from whether it's a provider fee or a prescription refill fee that is not covered under the terms of the plan. So those then get billed towards the participant, but the participant went in network. And so again, like, put yourself in the shoes of the participant and you're like, why am I paying $25 facility fee essentially to go see a doctor that's in network? So that's where those provider contracts really can come in. Those provider contracts that plan sponsor you attested that you have seen and you have access to, and you can see the cost and quality information. And so can I, as a participant, under the gag clause attestation. I mean, so take a look, rethink that one. See if you can even get some of those due to proprietary and confidential information, which is, again, I'm speaking to the self-insured population. Fully insured, dude, you're renting the network, you get what you pay for. You pay for a lot, but it's really none of your business. Self-insured, it is your business. It's entirely your business to know. It's your plan. So find that information. And then the other thing on the mental health thing is we've got the NQTL. It's not a new law. Regulations are confusing, but they did add a certification requirement in the final rule that says this is great, honestly. It says that the new regulations require the plan fiduciary, the employer, that is the fiduciary, to certify within the document, the gold star 150-page straight A parity document, that they engaged in a prudent process and monitored their service provider. Oh, that is so loaded with opportunity and liability to cause an impact on your plan and your plan participants.
So just to clarify, what NQTLs are non-quantitative plan limits. And so treatment limits. So these are things like paying mental health providers Medicaid rates when you've decided to adopt a Medicare reference-based plan and you're paying everybody else a Medicare rate, because we know Medicaid rates are pretty low and it does limit the number of providers who will accept that as a payment term. So,
hey Ann, it's Steve again for a second. I'm just looking through the Q&A, and there is so much interest and questions around this ghost network, as you might imagine. And one of the common ones, just to kind of aggregate them, is how do you know you have a ghost network, and what can you do about having a ghost network?
You really need to go through and have somebody come out and look at what are these providers really a network? And one of the things that drives me absolutely insane, because I used to sit next to the provider relations people at an insurance company, and I literally saw a post from a mental health provider saying Cigna would not accept her in network because they claimed that their network was sufficient. And so for me, I really believe that adopting a any willing provider, right? Set your rates and then adopt an any willing provider model and require your insurance company or your TPA to accept as in network any provider who is willing to adopt those terms. Because fundamentally, the crisis is so real. And I've heard of people waiting 8, 9, 12 months to get into a provider, and their child is in crisis yesterday, or they're boarding in an emergency room. And let's be real, boarding in an emergency room or having to go into an inpatient situation is so much more expensive than getting that treatment on the outpatient side.
Yeah.
And speaking from
I knew
personal experience, like we've gone and we've got the list of orthos. Here's what you do in real life. You look it up online through your tool. You see that your provider is in network. It shows in network Dr. X. You take a picture of it with your phone and you go see Dr. X. And then Dr. X says, I'm not in network. Now you have proof that you have you have not real-time updated the transparency thing. And then now you have a thing to start from, right? It's got to be accurate and timely, updated monthly, and pushed out. That's how you flesh it out. Like, it's a pain, right? It's a pain, but y'all are paying a whole lot of money and not getting anywhere otherpiece.
Yeah.
And we
a couple of other thoughts for you. Hey, we're also excited about mental health. It's not even funny, but the piece that I was going to say was I actually did a full audit on a very large, big 3 insurance carrier. And over 50% of the entries in their network directory were wrong and had patient impacting. So it wasn't just like a little misspelling or a typo, right? Something like this: patient impacting, provider not in network, and so on. And so that's one way to do it, right? Is to literally audit the network. The other thing I would say is that, one of my experiences was I was responsible for bringing a digital mental health app to market. And where we focused it was on exactly this issue, as you said, Ann. It often takes 6 to 9 months to get in to see a provider. What do you do in the meantime? You have to have a solution, and that solution was to give them some virtual tools, to be able to manage pieces of this, right? And that'll work for some populations. It won't work for all, and you need to kind of work through that.
So I want to close out this conversation. It's been really robust. I know we could probably and will go on for an entire hour on this in May for Mental Health Awareness Month. We're going to talk even more about network parity and what MAPIA actually means. So as we kind of move on from this slide, Jennifer, you're going to talk about some of the emerging trends in health plan discrimination and wellness plans.
Yeah, so this is an area that is getting a new uptick in litigation. Not quite sure why, but okay, fine. So what happens is HIPAA, right, is the PHI health factor, protected health information. And by and large, it says, plan, you cannot discriminate against consumer or participant based on a health factor, a health status, age, and here in this thing, it's going to be smoking status. And if you do, when it's got to either be benign, I mean, you can discriminate in favor of a diabetic by providing free glucometers and testing strips and all that jazz, but you can't do adverse discrimination for something health factor unless it's through a HIPAA compliant wellness program. This is part of the ACA, which means you have to have 5 things, primarily a reasonable alternative. So you're a smoker, it's an addiction. The EEOC says it's an addiction. And so it is not reasonable to pull the thing out of their mouth and tell them to stop. It is reasonable to say you need to go to your physician and see about something. What can we do? That participant does it timely, and they submit that paperwork, then they are made whole, which means if you are surcharging, if you're adding a penalty to that participant for their addiction, and they comply by doing something reasonable, you make them whole by giving them their money back, not going forward, but give them their money back, put them in the same position. And you do that year over year, and then if you don't, now you are discriminating. And, again, this is within, the other thing is it's got to be voluntary. We don't quite know what voluntary is because the EEOC won't say what it is, but we say somewhere around 30% of the cost of coverage, which is pretty steep. But anyway, that's where you seek legal counsel, look at your wellness program. They are not one size fit all, but they can be done. They just need to be done compliantly. And then to Ann's point, doesn't mean you won't get sued. It just means you'll have a defense. So that's tobacco in a nutshell with wellness programs.
Thanks. So to close us out, I think my comments will also come to some of our solutions. These are solutions that Steve and I offer. Some of them overlap with Jennifer's, but you're never not going to get sued. Anyone can sue you for any time. But what we are really looking to help you with is to meet these motions to dismiss, get a summary judgment. And you can't create an accounting system where nobody can steal from you because you would never be able to input or take money out. But what you can do is identify when people will steal from you. And so we really want you to get out of the mud puddle, onto the road to success. We're all very passionate about the healthcare ecosystem. We all bring a slightly different perspective. And, we want to help you be educated, educate your customers, get them onto the road to success, and start remembering that fundamentally, this is your plan. This is not a plan that a TPA owns. We have a comment here that around state law. Remember, ERISA preempts state law, and fundamentally, you are responsible for what that plan looks like. So you can make demands that might seem crazy today, but really that's just setting the trend for the market for tomorrow. And we want to help you do that because fundamentally the market today is broken for patients, and that means it's broken for your participants. Jennifer, why don't you walk the audience through some of your specialties and the opportunities to work with you?
Yeah, thank you. Stanley Cup Legal and Compliance. I am a practicing attorney here and licensed in Texas, but I work on the consulting side as well with plan sponsors, employers, those just offering a benefit. And then also with point solutions, TPAs, PBMs, really, equal opportunity here because at the end of the day, this is a hard, nuanced space. And it's at boutique brokers. That's where I started, got my roots. So really and truly, it's about partnering with people that know there's a problem and are willing to address the problem with solutions. I don't consider myself an ERISA attorney because that would knock out to a question here is like, that knocks out public sector or church plans. Why would I want to do that? Just because a public sector plan is not governed by ERISA, a lot of states are starting to regulate their own public sector plans. So whether it's through the PBM space, whether it's through just their own, like saying you are or are not part of this area. Remember, that would happen at the state legislature. So that's not a great thing to just say, oh, we're not ERISA, so nothing fiduciary applies. Dude, you might have more. I don't know, it depends on what state you're in and how regulated that state is. And then on your church plans, again, that's another area where even if ERISA doesn't apply, well, you might think it doesn't, but what if your documents actually said it does? And ERISA is not bad. It can actually protect you from state liability. But again, now you have the bars. You have those set bars of what you must do. So that's where it comes in. It comes in that personal touch, looking and being an unbiased third party, making sure you can rightly certify that your 5-star grade A TPA provided analysis for the way the network works is really the way the network works. And the only way to do that is to get in there and see how it works. So that's
a little diligence. So, hey, just looking at our time here, and we've got about 4 minutes left. You guys have done a good job of addressing some of the questions in the chat. And I know you just touched on a couple of, Jennifer, and we touched on some of the ghost networks and mental health pieces. But in just the time remaining, why don't we do just a very quick rapid fire? I'll throw out some of the questions here. You guys can answer it quickly, and then there are some really detailed questions that we'll have to get back to you via email. And so the first one, there's two of them that I really like and simple, right? Anne, what's your best pro tip for an employer?
Process, right? I mean, most employers have processes. They are probably doing some sort of quality improvement across their organization. You want to bring that to your health plan. You don't want to simply sit there as a passive participant and say yes to things that people are bringing you at this point. You really want to evaluate and document that evaluation.
So awesome. Jennifer, similarly, and I love it that people are adopting your your terminology. How do we get out of the mud puddle and start it on the path?
Yeah, I think you partner with people and entities that want to also partner and don't have a conflict of interest. There's, questions about what if we have vertically integrated? Well, what if your consultant is also, doing, I don't know. We really need to have arm's length oversight, transparency, so that those things can come out. It's really awkward doing a comp disclosure when it's not new, right? It's really awkward doing a comp disclosure when somebody hasn't fully disclosed their comp. It's awkward. Start with the basics, guys. Start with the basics.
Yeah. Well, you mentioned awkward, like one of the things I hear all the time is, brokers today are required to disclose their compensation, and they often aren't. Right. And in turn, you need to ask them for disclosure and, use discipline to drive for full disclosure. And, I've heard people say, well, they're our friends and they've helped us forever and we trust them. And none of those are good answers. Right. It's trust, but verify and start there. Start there for sure. So, hey, Ann, I think we're probably done with Q&A. We'll get back to everybody else with email. And so in the meantime, just want to thank everybody for joining the webinar. And we have talked a ton about fiduciary duties today, and there's a lot to unlock in there. So as a parting gift, we're going to send everybody, all the attendees here, a fiduciary handbook, right? And it's all about how to be a responsible fiduciary, how to establish and run a high-performing fiduciary committee, and ultimately how to get out of the mud puddle and be on the path to a really great compliance journey.
And Jennifer's information is not available here, I'm afraid, because of our faces, but we will certainly send out how to contact her in the follow-up email, where you'll see Steve's gift, the Fiduciary Advantage, and as well as some of the slides and responses to the question. And depending on how things go, also a copy of the recording. Thank you so much, everyone, and have a great day.
Thanks, everyone.